Today's session is on the male and female perineum. The objectives include reviewing the borders of the pelvic outlet so that the perineum can be defined when the patient is being examined in the lithotomy position. We will identify the borders of the urogenital triangle and anal triangle and the important landmarks so that an episiotomy can be performed during parturition. We will characterize the location of the ischial-rectal fossa and talk about how the pudendal nerve runs through it. The pudendal nerve is the primary nerve of the perineum. We will identify and define the perineal body as a major landmark in the perineum. We will describe the superficial and deep pouches and their contents. We will explain the mechanism of erection and talk a little bit about how Viagra works. And we will discuss clinical examination of the breast and what you might observe. And then finally talk about important features of urinary catheterization. So the lithotomy position for the female examination of the perineum has a very long history. The term lithotomy comes from the Greek word, basically two words, lithos and tomos, which means stone and to cut out. Apparently this was the position that the patient was placed to try to remove both kidney stones and gallstones. Not quite sure how they did that, but anyway, that's where the word comes from. This position really is the easiest for the physician, not necessarily the patient. But typically it's a situation where the patient lies on her back on the table, and then legs are put up in stirrups above the hip level, and then the feet are placed in those stirrups. Yeah, so in the male, it's a little bit different. Male is usually placed on a flat table or an inverting table, and then positioned in what's called the jackknife position, essentially lying on one side and then flexing the inside leg. We'll be discussing the perineum today. It's a very narrow area, but critically important, and will include the external genitalia, the urethra, several muscles that are necessary for voiding the bladder, as well as the sexual response, and a number of glands as well. So just to review the pelvic space, we talked about this last time, but essentially it's the area beginning at the pelvic brim. As you may recall, the superior border of the pelvis is the perineum, the peritoneal cavity that can vary kind of in between the iliac crest and the pelvic brim. But we talk about the pelvic inlet, the pelvic brim, as the superior aspect, and then the inferior aspect is the pelvic outlet, bounded by the pubic bone, the ischial tuberosities, and the coccyx. If we look at this directly from the prone position, we can basically draw a diamond between the coccygeal region, the coccyx, to the ischial tuberosity, to the pubic bone, and then we can run a line in the middle that runs through the perineal body, right about there, and that divides it into a UG triangle and an anal triangle posteriorly. So we need to think about this. Actually, kind of the best way to perceive this is by looking at a coronal section, and we do that in this image here. So you can see the perineum forming the superior border of the pelvic space, and then the pelvic diaphragm, you recall the levator ani and the coccygeal muscles, forming the inferior boundary. And then below that inferior boundary, what we're going to see is this UG diaphragm, and that is going to form a space between a set of muscles, the UG diaphragm, and the skin. So our perineum is really this space down here. So pelvic space here, the perineum below that pelvic diaphragm. But these two spaces aren't really completely separated, and many of the structures that are in one are also found in the other. So we tend to talk about this as two separate spaces, and we will do that today primarily just so that you can understand it a little bit better. I think looking at it as two separate spaces provides us with a little bit better conceptual concept. So when we look at those two triangles, we mentioned this last time, there are the diamond itself ends up creating, or at least we can think about this in terms of two triangles. Like I said, a line can be drawn through the perineal body. And if we look at the posterior aspect, here, we can see the anus right there, and we see two big spaces here and here. Those are the ischiorectal fossae. The ischiorectal fossa, these are two big spaces. Notice how up here the UG diaphragm seals off the pelvic diaphragm, but back here there's nothing to seal it off. So in fact, we see these two big spaces called the ischiorectal fossa. Typically these are filled with fat and allows movement of the rectum and also to some extent the bladder. Looking at this at a coronal section, we can see that this ischiorectal fossa is underneath the pelvic diaphragm. There's the pelvic diaphragm, obturator internus, ischiorectal fossa right here, and we're going to see very important nerves and arteries that are going to run through there. Just recall from last time, when we look at this perineum, this diamond, it looks like a flat structure. It really isn't. It runs from the pubic bone, the UG diaphragm, runs from the pubic bone back, perineal body's down here someplace, and then up to the coccygeus. So the anal triangle is positioned at about a 35 to 45 degree angle. The anal triangle, of course, receives the rectum, the anal canal, and then the anus. Okay, so let's talk about the separation between the UG diaphragm and the, or I should say the UG triangle and the anal triangle. And you recall back when we looked at embryology of this area, the urorectal septum was this chunk of tissue that runs down, and then inserts into the cloaca. There's a cloacal membrane right about there. Runs down, connects, and that's the perineal body. The perineal body splits the developing hindgut into a UG system anteriorly and the alimentary canal posteriorly. So the septum actually is even seen in the adult. We talked about that last week, as I recall. It's called the rectovesicular septum. It's basically a connective tissue septum between the urinary bladder and the vagina, because the urinary bladder is going to split. It's between the vagina and the rectum as well. There's a vesiculogenital. That's not right. Vesiculo-uterine septum as well. So there's a septum between the bladder and the vagina, and then there's a septum between the vagina and the rectum. And we talked about how those walls can weaken, particularly during childbirth, and we can have a herniation of either the intestine into that space, the rectum can herniate into that space, a rectocele, a bladder can herniate into the vagina, and that's a cystocele. So you should go back over that. Anyway, the perineal body is seen not only in the embryo as it forms, but we even see that in the adult. In this adult male, we can see this whitish tissue right here, and that's the perineal body forming a very important landmark between the external genitalia and the anus posteriorly. The perineal body is indicated by a muscle, and we're going to see three muscles in this UG diaphragm. We're going to see one right from the ischial tuberosity to the perineal body, and this is called the superficial perineus body, superficial perineal body, superficial perineal muscle. I'm sorry, it's late in the day, and I've been talking a lot today, so I'm going to try to keep these terms straight. But anyway, very superficial, very delicate muscle, but it is important because it stabilizes the perineal body, and it helps, in fact, to stabilize the entire UG diaphragm. In a minute here, we're going to talk about the other muscles. There's an ischiocavernosus muscle and a bulbospongiosus muscle back down to the perineal body. So we have this nice little triangle in the UG diaphragm. We'll talk about that in a minute. But right now we're talking about the perineal body, this massive connective tissue. It's basically where the muscles converge and they overlap, and they form a continuous connective tissue core. This is a very important area for childbirth because as the baby's head crowns through the vagina, perineal body's right here, and it can tear, right? And you've got to be really careful about that because that can tear right into the rectum, into the anus, and then into the rectum. So sometimes what the physician will do, the OBGYN will actually make a little incision there in order to kind of control that tear. I mean, if it appears as though that tear is going to happen or it starts, the physician will actually open that up. Be careful, carefully not hitting the anal sphincter, which is just posterior to the perineal body. So anyway, the perineal body, very important landmark here, a primary area for insertion of muscles. Notice that the pelvic diaphragm does not really insert into the perineal body. That's all up above the UG diaphragm, which is this space right here in the anterior aspect of the pelvic outlet. Okay, so we're still talking about this ischiorectal fossa, this space posterior to the UG triangle, and I showed you that big space there, the big cavity, the ischiorectal fossa. It contains primarily fat, but there's a very important canal that runs through here called the pudendal canal, and the pudendal canal runs right up against the obturator internus. So if we take a coronal section through the ischiorectal fossa, what we see is the obturator internus muscle forming the lateral wall of the pelvis, as we've talked about previously, and we noted how the levator ani will kind of hammock off that obturator internus. Well, down here in the ischiorectal fossa is a lot of adipose, but what we see on the lateral wall is we see a canal, and that's called the pudendal canal. It's essentially a fascial canal, and we have very important nerves and arteries that run through there. Essentially, those nerves and arteries, that pudendal canal is a transit point for the nerves and arteries to go from essentially the posterior aspect through the internal aspect of the pelvis, goes out the greater sciatic foramen back in the lesser sciatic foramen, and then runs along that obturator internus to get to the external genitalia. So we'll talk more about the nerve innervation of this area, but essentially pudendal canal comes off S2, 3, and 4, runs out the greater sciatic foramen, but then shoots around the sacroischial ligament, and then runs into the pudendal canal, runs forward along the obturator internus, and then supplies the external genitalia. This nerve is quite large. You can't really get much of a orientation on this. All I can say really is here's the anus here. This is all the ischiorectal fossa here. And what we can see here is this big pudendal nerve. See that nerve right there? It's going out the greater, back into the pudendal canal through the ischiorectal fossa, and it's going to go forward. You can kind of see it here in this illustration. Out the greater sciatic, runs around the sacrospinous ligament, inside the sacrotuberous, and then along the obturator internus to get to the external genitalia. So important things to think about. That pudendal nerve is particularly important here because what it does is it, as we're going to see next week, is it supplies rectal nerves to the inferior rectal nerves to the sphincter muscles, the external anal sphincter. So it's very important. It's a somatic nerve, right? So you can hold it for a while because you can constrict your external anal sphincter, and that's all through the inferior rectal from the pudendal nerve that runs in this pudendal cavity. Okay, so let's move on then, and now we can talk about the UG triangle a little bit more here. So to understand the perineum, the best way to think about this is that there are two pouches in the perineum. In other words, there are two little spaces that contain structures. And one is a deep perineal pouch, so that's closer to the pelvis, right? It's closer to the pelvic space, closer to the pelvic diaphragm. And then there is a superficial pouch, which is more superficial, so it includes the skin. So we have, I think, a pretty good illustration here. Here's a female perineum, and just for reference, we can see the uterus here, and the section is going through the vagina. And what we're seeing here then is this kind of this anterior area that the pelvic diaphragm is down here, that UG triangle. We're all in the UG triangle here. So as we mentioned, the pelvic diaphragm is forming the inferior border of the pelvis, and then the UG triangle, inside the UG triangle is this UG diaphragm, urogenital diaphragm right here, and that's forming the superior border of the perineum. The inferior border of the perineum is the skin. All right, so that's all the skin there. So essentially the space is really narrow, but there's very important structures in there, and that's why it's kind of deserves its own space, so to speak. So there are two layers, as we mentioned. The first layer is the deep space, and you can see it right here, and that's occupied essentially by muscles, and we'll talk about those muscles in a second. But essentially they're horizontally placed muscles that run from the ischium, midline, and then they connect to a raphe in the middle. So that's essentially just a muscle layer. What we're also going to see there is there's fascia on these layers. There's fascia above here, fascia below. The fascia all over the place, but the one fascia layer that we give a name to is a fascial layer just along the inferior border of the UG diaphragm, and that's called the perineal membrane. These arrows got bumped a little bit, sorry about that, but essentially the perineal membrane is this membrane right below the pelvic diaphragm. That's significant because it's fairly thick, and in episiotomy, you can suture to that, or in different perineal operations. This stuff is very thin, and it's hard to anchor to it. But this perineal membrane is pretty thick, so people will, or I'll have you identify that, because that is an important clinical landmark in terms of being able to suture to it. Okay, so the deep space then is this UG diaphragm along with the perineal membrane, and then the superficial space is closer to the skin. So here we're going to see a superficial space from that perineal membrane down to the skin, and what we see here is we're going to see the erectile tissues. So there's erectile tissues in here. I'm going to show you more pictures in a second, but there are erectile tissues in here that are essentially sinuses, blood sinuses. So they're spaces that remain constricted due to sympathetic activity, but upon parasympathetic activity, they relax and blood comes into those spaces. So those are erectile bodies that we'll talk about in a minute. And then there are muscles around those erectile tissues. They wrap around, and again, they're going to help control the amount of blood in those erectile tissues. So we're going to see blood in there. And then finally, we're going to see nerves, arteries, and veins that are going to course through the superficial pouch. Okay, so just to reiterate then, we've got a deep pouch, which contains muscle, the UG diaphragm, and then we've got a superficial pouch, which is going to include the erectile tissues, some more somatic muscles that we can they're affected in various ways, but anyway, there are muscles here in the superficial pouch, as well as nerves, arteries, and veins. Okay, so that's an important concept. Deep pouch with muscle, UG diaphragm, superficial pouch with muscle as well, but the erectile tissues and nerves, arteries, and veins. Okay, and I'll try to fix that up before I post the. I'll try to fix these arrows up before I post the lecture. All right, so let's talk about these things a little bit more specifically. We can talk about the deep pouch and the superficial pouch. So the deep pouch and the superficial pouch have some of the same structures in both male and female. So the deep pouch itself is essentially a composite muscle, and it's thin, but nonetheless it's pretty important. It's pretty significant. So in the male, what we see is a deep transverse peroneus muscle, and we're going to have both a deep in this UG diaphragm as well as one more superficially called the superficial peroneus muscle, that one I showed you initially. And then we have this thing called the sphincter urethrae muscle, and this muscle runs up and it wraps around the urethra. It comes up from kind of both sides and wraps around the urethra, and that helps make the sphincter an external sphincter. So when you do your Kegel exercises, you're affecting the pelvic diaphragm, but you're also working the UG diaphragm. And again, we're going to see some glands and vessels essentially superficial to this. The deep pouch itself is essentially these two muscles, the sphincter urethrae muscle and the deep transversus peroneus muscle. It will also include the urethra's got to go through there, right? So we're going to see the urethra, and then there are glands. There's Cowper's glands, and also in the female Bartholin gland as well will be seen here. So deep pouch, both in male and female, both have a sphincter urethrae muscle, and both have a deep transversus peroneus muscle. Superficial pouch is, again, kind of the same. It has the same major players. They're just different sizes. And what we're going to see here is a bilateral triangle. So you can kind of think of this as a superficial peroneus muscle that's going to insert into the perineal body there. And then we have a what's called an ischiocavernosus muscle that runs up lateral on both sides. And then we have a bulbospongiosus that runs right through the middle, right? So we kind of have these two bilateral triangles on either side of the either the penis or the vagina, and it's bounded by three muscles: superficial transversus peroneus, the ischiocavernosus, and the bulbospongiosus. And female, it's basically the same. It's the erectile tissues are a little different, but pretty much the same. And then the external anal sphincter positioned behind in the anal triangle. All right, so this is our general configuration: a deep pouch with transverse muscles that go across primarily to work as a sphincter for the urethra, and then a superficial pouch, which we have are three bilateral muscles: superficial peroneus, bulbospongiosus, ischiocavernosus, and these are going to help both contract the urethra, or at least help move urine down the urethra, but maybe more importantly, they are to mediate the function of the erectile tissues. All right, so let's look at this a little bit more specifically, let's talk about the erectile tissue. So underneath those muscles, those three muscles is very dark sinus tissue. I mean, it appears black actually in the cadaver. And these are erectile tissues, and they're essentially a meshwork of very small sinuses that are endothelial lined. And we don't really call them veins or arteries. They're kind of in between the arterial system and the venous system. And they sit right underneath these muscles. And the terminology is going to vary a bit, not only between male and female, but people use different terms a bit. You can think of these as erectile bodies, okay? Erectile bodies. So as a result of it being an erectile body, we use the word corpus. We use the word corpus. So in the male, we're going to have a corpus cavernosum, which is underneath the muscle, which is the ischiocavernosus. And we're going to have a corpus spongiosum, which is right in the middle, and that's underneath the bulbospongiosus. All right, so the corpus spongiosum underneath the bulbospongiosus. We have a couple of other terms you're going to hear. The crus of the penis and also the crus of the clitoris is just this kind of pointed structure, kind of the curve that comes off the ischial tuberosity. These are, or the ischioramus. These are these erectile tissues are kind of stuck onto the bone. It provides a good foundation, a good basis for the erectile tissues. Okay, so in the penis, then this we're holding up the shaft of the penis. Right in the middle is the erectile tissue that wraps around the urethra, and that's the corpora spongiosum, and then the corpora cavernosum is on either side, and that's going to eventually get to the glands. So in this illustration, you can see how the corpora cavernosus is coming up, but it's actually the bulbospongiosus that comes up and creates the glands. I'll show you that in another picture. A couple of other structures in the male. There's a bulb of the penis, which gives rise to the spongiosum, the bulbospongiosus. And in the female, there's a bulb of the vagina, which is we'll look at that as well. But that's, again, this is where the terminology gets a little bit confusing. So what I just want you to know is that they're erectile tissues, and then they are covered by muscles. The erectile tissues are called corpora cavernosa, corpus spongiosum in the male, and they are covered by the ischiocavernosus and the bulbospongiosus, again in the male. And that's pretty much the same for the female that we'll mention in a second. Okay, I hope that makes sense. Just don't get too weighted down in the terminology. All right, moving on then. Let's look at the penis a little bit more. Penis is basically a common outlet for both urine and semen, and as I mentioned, it's composed of a bulb and a root and a body and a glands. And there are three erectile bodies, the two cavernosum, corpora cavernosum on the sides, and then the bulbospongiosus together. If we make a cut through the shaft of the penis, what we see is the two corpora cavernosa on either side, and there are deep arteries, and these are very important arteries, deep artery of the penis, because what happens, that's going to bring blood into the penis, and during the sexual response, that blood comes into the penis and then will flow into these sinuses, the erectile tissue, and engorge them. And then that's due to parasympathetic innervation, and then sympathetic innervation will close these down, and then the blood goes into the deep and dorsal, the dorsal vein of the penis, both the superficial and the deep. So the blood comes in through these and then out through these deep veins. If we take a section through the penis, you can see these things. Here's the erectile tissue here and here, and you can see these sinuses that are formed. Here's the urethra, and then the corpora spongiosum, which isn't quite as big. Also note that there are some fascial layers. Each one of these will have a fascial layer around it called the tunica albuginea. And there's some around the corpora, there's another around the corpus cavernosum, some around the spongiosum as well. And then there is another one called Buck's fascia that wraps the whole way around. All right, so we kind of have these three layers of fascia. The tunica albuginea is relevant because it's actually around the testes as well. So that wraps basically around the testicles all the way up into the shaft of the penis. Okay, so just talking a little bit more about then the process of erection in the male. Blood is coming through these dorsal arteries, and typically there is sympathetic activity which keeps these vessels contracted, and there's kind of a slow flow of blood through these sinusoids into the dorsal vein of the penis, and the penis is flaccid as a result. With sexual arousal, essentially what happens is parasympathetic innervation takes over. It dilates all these sinuses and the vessels as well, and blood comes in. Meanwhile, the ischiocavernosus and the bulbospongiosus, the muscles are contracting, and that's keeping blood in the penis, and as a result, it's erect. The various ED medicines these days, Viagra is a good example, is really pretty straightforward. It inhibits cyclic GMP, and it essentially keeps these vessels dilated, so it counteracts any sort of sympathetic activity and just keeps these vessels engorged. And then ejaculation is a sympathetic activity, and so when that takes over, then these vessels will close down, and all the blood will run through the superficial and deep dorsal veins of the penis. We refer to a number of small arteries that are bringing blood into the shaft of the penis as Helicene arteries, and that's essentially the sinusoid system. So you may hear that term, but just understand it's the sinusoids of the shaft of the penis. Okay, so the other external genitalia feature is the scrotum, and we talked about this. We talked about the anterior wall of the abdomen because of its close relationship. As you probably recall, in the baby, the scrotum grows from the anterior abdominal wall, and it pushes out, and as a result, it takes the layers of the anterior abdominal wall with it. As you recall, the layers included the transversalis, the superficial fascia, Campers and Scarpas, and then we had the external abdominal obliques, the internal abdominal obliques, the transversus abdominis, and then finally the transversalis fascia. All of those will be represented in the spermatic cord, right, as the testicle, which forms up in the abdomen, runs down through the anterior abdominal wall. The opening is called the deep inguinal ring, and then the testis runs through the superficial inguinal ring, which is on the anterior wall, and pulls all of these fascial layers down with it. So as a result, when you actually dissect the testicle, you can see these layers. And then recall the testicle has seminiferous tubules, reedy testes that goes into the epididymis, and then the epididymis forms the vas. The vas comes up through the spermatic cord, all around the posterior abdominal wall, underneath the urinary bladder, joins with the duct of the seminal vesicle, makes the ejaculatory duct, and then that's out the urethra. So that's the whole pathway, and you should be aware of that pathway. You can take this opportunity to review the contents of the spermatic cord. Here's the Sketchfab model. That kind of got overlapped there, but anyway, I'll have that posted in a list of models. In terms of clinical exam for a hernia, again, I believe we talked about this for the anterior abdominal wall, but you have this superficial inguinal ring, which really represents kind of a soft spot, right? Because all those structures in the spermatic cord are coming through. So what the physician will do is place his fingers in the area of the superficial inguinal ring, ask the patient to cough. That cough will increase abdominal pressure. The abdominal pressure will push on the intestine, for example, and if there is a weakness there, that intestine will pop through and the physician will feel that. And he can feel for both indirect and a direct hernia relative to the superficial inguinal ring. And again, recall the continuity: testis, epididymis, vas, through the spermatic cord, runs the whole way up or along the posterior abdominal wall, and then runs underneath, and then is going to join the seminal vesicle and go through the prostate into the prostatic urethra. And then there's a short membranous urethra that goes through the deep, the UG triangle, and then spongy urethra out the penis. All right, then. Let's talk about the female situation. Again, a lot of similarities in the sense that there is a superficial pouch and a deep pouch. The deep pouch is going to be structured pretty much the same. There is a deep transverse perineus muscle that runs across, and then this sphincter urethra that's going to run up around the urethra, form a sphincter. Of course, the vagina is there, so you're not going to have as many muscle fibers, so it's a little harder to keep that urethra contracted in some cases, just due to the fact that you just don't have the muscle bulk there. But same idea as in the male, right? A sphincter urethra versus a deep transversus perineus muscle. The UG triangle, the superficial pouch, again, will have some of the same structures. We're going to have three muscles: a superficial transversus perineus, we're going to have ischiocavernosus, and then we're going to have a bulbospongiosis. Same thing as in the male. The only thing is, in the female, we have the vestibule, the vagina and the urethra, labia minora here, so that you have erectile tissue here, which is fairly significant. We just call that something a little different. We call it the bulb of the vestibule. So in the female, we have a bulb of the vestibule, which is really the corpora spongiosis, or corpora spongiosis in the male, but we just call that the bulb of the vestibule. But if you call it the the corpora spongiosis, if you call the erectile tissue in the female the corpora spongiosis, corpora spongiosum, everybody's going to know what you're talking about. And it's the same thing laterally. We tend to call this the crus of the clitoris, but you can call it the corpora cavernosum as well, and nobody's gonna bother you about that. The two the erectile tissues run up and join the clitoris, as do the bulb of the vestibule. All right, so you can see that here running up into the clitoris, located here. So same general idea, just not quite the same. There is a fairly large gland here called the vestibular gland, also referred to as Bartholin's gland, and this can become infected, and it can become quite enlarged actually. So it's something you want to keep your eye on. Okay, so I hope that makes sense. Same kind of idea. You have this triangulation of the muscles on both sides, ischiocavernosus on both sides, transversus peroneus, and then bulbospongiosis. The only difference is the vagina will separate these much more in the female than in the male. But same idea, superficial and a deep space. All right. So continuing on, talking a little bit about the structures in both the male and female. This is a model you can look at, but essentially this is the deep pouch in the female. And of course, I know that because there's a large vaginal orifice as well as a urethral orifice. And there's going to be a membrane here. That's the perineal membrane. And on your model, you can see that pretty well. It's all in white. And it's a relatively thick membrane. It's just the fascia that's on the UG diaphragm in that deep pouch, right? So it's fairly thick and you can suture to it. So in this illustration, you can see the perineal membrane right here. And on the cadaver in particular, it's very obvious. It's a very thick fascia. And you should go through these models. One has the muscles and the other has the erectile bodies in the female. The male's basically the same, outside of the fact that the bulbospongiosis is connected midline. And you can actually see these things on the patient. This is a transrectal, that's a combination of an ultrasound and a MR. But you can see all of this. Again, this kind of got crunched up. I'll try to fix that for you. But the transrectal probe is placed in the rectum, and you can see the external anal sphincter here around the rectum, as well as the anal-coccygeal ligament. And then you can really see this triangle up in here, right? The urethra, you can see the vagina's collapsed, so you can't see it all that well. But you can see the ischiocavernosus here. I'll get rid of that. You can see the ischiocavernosus here. You can see the transversus peroneus here. You can't really see the bulbospongiosis all that well, but you see it a little bit right in there. So all of these structures are visible. And again, this is going to become a very important area in the pregnant female. You can see the perineal body is going to be right about here, very close to the rectum and the vagina, so you can understand how that can split. So when you're telling the patient to push, they have to push for a while, but as soon as that head comes through, they stop pushing because you don't want them to contract this so much that the muscle tears. Okay, so I put that up there. Sometimes students don't believe any of this stuff exists because it is so confusing and so small, but in fact it does exist. So external genitalia in the female, we're looking at the UG triangle here, located again from the pubic bone down to the ischial tuberosities. And from the coronal view, there's the deep pouch with the muscle, and all this external genitalia is located in the superficial pouch, right, from the UG diaphragm to the skin. So the components, we call this space really with the structures, with the external genitalia of the vulva. The mons pubis is the enlargement, kind of a bump anteriorly. Adipose is located there. Labia majora, essentially analogous to the scrotum, located laterally. The minora is on the inside and smaller, and this really is what describes the vestibule with the vagina and the urethra, and then anterior is the clitoris. Keep in mind these vestibular glands located there and there. As I said, they can get infected, and you can see that here. We're looking at the vestibule. You see the labia minora there, the urethra, the vagina, and you can see this enlargement here, which is a Bartholin's gland, can get infected and be quite painful. And again, you should just review this on your pictures, as well as I think we may have a model of this as well that you can review. Okay. So let's talk about the duct system. We've described this already in the male, but just to very quickly review, we have the testicle, the seminiferous tubules. Oops, sorry. The seminiferous tubules are in the testes. They go into the Redes testes. The sperm is delivered to the epididymis. Epididymis comes down and then becomes the vas. And then the vas is going to run up through the inguinal canal, posterior aspect, joins with the seminal vesicle here. We see seminal vesicle right here. And these will join together to form the ejaculatory duct. So this is essentially a small duct that's going to run through the prostate and then into the prostatic urethra, membranous urethra right about here, and then the deep pouch, the UG diaphragm, is right about here. So there's a small membranous urethra. So the prostatic urethra here becomes the membranous urethra here, and then the spongy urethra after the UG diaphragm continues out. You should know the course of sperm and the anatomical structures that it traverses. And I just put just a histology picture up here so you can be convinced that there are spermatic seminiferous tubules that go up into the Redes and then down through the ductus down to the epididymis and into the duct. Various layers on the testicle as well. That testicle is surrounded by all of these layers of the spermatic cord. And then the very thick tunica albuginea, which is the outside. You can see it in this illustration here, this very thick connective tissue. You should be able to recognize these things. This is a picture from the posterior aspect of the reproductive system, the duct system in the male, and there are models that you can work with, but we see the vas here, the seminiferous tubule here. These are going to combine into the ejaculatory duct that goes through a relatively large prostate here. All right, so you should be familiar with the duct system in the male and the procedure, or the pathway. Female duct system is, sorry, I'm kind of slouching down here. The female duct system, we've talked about last time, the uterus with the fundus here, and the body. The oviducts will join into the uterus here. Large oviduct starts at the fimbria, which receives the egg from the ovary, so the egg continues down, uterine tube into the uterus. The uterus, the terminal aspect is the cervix, which connects with the vagina, and there's spaces along the cervix called the fornices here and here. There's an anterior one, a posterior one. But this is crucial information because you're going to take a pap smear from here to test for cancer cells, as well as you're going to just look at it, right? You're going to do a visual inspection of the cervix to make sure that it has the proper texture that it should. You should be able to identify all of this. You can see the uterus here, anteverted, and then the ovary position here with the fallopian tubes that are going to wrap around and go into the uterus as well. We're going to talk a little bit more about that next week when we talk about the uterine artery and the blood supply. Just looking at the uterus, so the uterus is covered by the peritoneum, right? So the peritoneum is going to just sits on top of the uterus, and we call that the broad ligament. And the broad ligament is going to condense in various areas. There is a relatively strong suspensory ligament of the a suspensory ligament of the ovary. So we have the ovary here, and then we have a condensation. The suspensory ligament. The suspensory ligament is out here. It connects the ovary to the lateral wall, and then there is an ovarian ligament that connects the ovary to the uterus. So suspensory ligament, because it suspends the ovary from the wall. We have the ovary itself, and then condensation of the broad ligament, which is really peritoneum, attaching into the uterus. And then we won't go over this, but we do give names to all of the various reflections of the broad ligament onto the ovary. The one I do want you to know, though, is the round ligament. The round ligament. So this is a ligament that runs anteriorly, and right about here is the deep inguinal ring in the female, and that ligament is going to curve out, and it's going to join into the labia majora. And that's very critical because it actually, I don't know if you can see my hand very well, but I mean, we can think of the vagina like this and the uterus going forward. And then the round ligament are these two ligaments that tether it to the anterior wall. And that's why this uterus keeps its anti-flexed, anteverted, not anti-flexed, but anteverted position. So the uterus remains forward. In elderly females, this starts to break down, and then what will happen is those two ligaments break down, and then the uterus can become retroverted and then prolapse. So these round ligaments are quite important, and you can see these pretty well when you do laparoscopic hysterectomy. You should be able to identify the round ligaments quite well. And they're critically important for helping the uterus maintain its position in the pelvis. So just a couple of clinical aspects. Pelvic exam, we talked about the lithotomy position. If you're ever stuck in an emergency situation without a table and stirrups, female can just hold her knees, and this is kind of a emergency situation. In terms of doing the physical exam, typically two fingers are inserted, and then above in the anterior abdominal wall, you press down to try to put the uterus in a position where you can palpate the cervix easy enough. And the cervix itself will look like this in a normal situation. However, it will vary according to kind of the hormonal situation. And then with cancer, for example, it'll become corrugated. The cervical os, it will open up, and you'll have a whole list of the cervix changes quite a bit with various pathologies. So if you do go into OBGYN, I'm sure you're going to be looking at those, the effects on the cervix and what that's going to look like. In terms of the breast exam, again, we talked about the breast previously, but you should visibly inspect it. You should palpate for lumps. You should indicate where those are and their distance from the the nipple itself. Back when we talked about the anterior thoracic wall, we talked about how the majority of the lumps are going to be found towards the axilla, and that's because the lymphatic drainage, the majority of it's running through the axillary nodes. So that's what you're going to be looking at. Inverted nipple, which can happen towards puberty. That a lot of times will rectify itself. However, you'll see that in cancer, and you'll see puckered skin as well. We talked about that with the anterior thoracic wall when we talked about the orange peel appearance of cancer as it tends to advance. The American Cancer Society recommends breast exam every 3 years for women in their 20s and 30s, and every year for women over 40. All right, and then finally, just catheterization of the urinary system, and you probably will be doing this at one time or another. Female is fairly straightforward in the sense that you identify the vestibule, identify the urethral opening, you'll swab this area, lubricate the tube, and gently push it up through the urethra into the bladder, and then you'll typically there are two ends on these things, one with a tube. There's two ends in the sense that the leading edge goes up into the bladder, and then this bubble will inflate, the balloon will inflate, and that makes sure that the catheter doesn't pop out. So once you push it in, you will try to pull on it just a bit to make sure the balloon has seated itself, but you don't want to pull too hard. And then you'll be able to take urine directly. So that's a Foley catheter. For male, it's pretty much the same. The big difference is really in the urethra is a lot longer. Females is about 3 to 4. Males is anywhere to 15 to 20 centimeters. So, and you got to navigate it a little bit, right? Because although you can straighten out the penis, the catheter is going to go up and has to curve through this membranous urethra. That's the little piece of urethra bounded by the UG diaphragm, and that's membranous. It's pretty fragile there, so that's possible you could break through the membrane there, but usually that's not going to happen. But nonetheless, you should be aware of that membranous urethra, and then the prostatic up into the bladder, and once into the bladder again, you'll enlarge the balloon, and it shouldn't come out. All right, so that takes care of the perineum, both the male and female perineum. So work through your module, and we'll see you in the synchronous activity. Thank you.